The femur is also called the thigh bone. It is the longest and the strongest bone of the body. Side determination: the upper ends bear a rounded head, the lower end is widely expanded to form two large condyles. The head is directed medially and the cylindrical shaft is convex forwards. So this is the head of the femur, the neck, the greater trochanter, and the two condyles of the femur. Anatomical position of the femur. The head is directed medially upwards and slightly forwards. The shaft is directed obliquely downwards and medially so that the lower surfaces of the two condyles of the femur lie in the same horizontal plane. Nutrient artery to the femur is derived from the second perforating artery, the branch of the profunda femoris artery. The nutrient foramen is located on the medial side of the linea aspera and directed upwards. Structure of the femur. The angles and the curvatures of the femur are strengthened on their concave sides by bony buttresses. The concavity of the neck shaft angle is strengthened by thickened buttress of compact bone known as calcar femorale. Similarly, the linea aspera is supported by another buttress. This mechanism helps in resisting stresses including that of the body weight. Now let's see the features of the femur. The head of the femur forms more than half of a sphere. It articulates with the acetabulum to form the hip joint. The neck of the femur is 3.7 centimeters long. It has two borders, the upper and the lower, two surfaces, anterior and the posterior. There is a roughened pit below and behind the center of the head. This is called the fovea. The quadrate tubercle is a rounded elevation. This is the intertrochanteric crest, the spiral line, and the lesser trochanter. The lesser trochanter is a conical eminence directed medially and backwards from the junction of posterior inferior part of the neck with the shaft. Then we have the greater trochanter. It is a large quadrangular prominence located at the upper part of the junction of the neck with the shaft. It has an apex, three surfaces, that is anterior, medial, and the lateral. This is the shaft of the femur. Then we have the linea aspera, the medial and the lateral supracondylar lines, the popliteal surface, the intercondylar fossa. This is the medial condyle and that is the lateral epicondyle, the lateral condyle, the adductor tubercle, and the articular surface for the patella. The shaft of the femur is cylindrical. It is narrowest in the middle, expanded inferiorly, then superiorly. The middle one-third has three borders, that is medial, lateral, and the posterior, and three surfaces, that is anterior, medial, and lateral. Attachments of the femur. Anteriorly, we have the capsular ligament, the psoas major, the vastus medialis, the piriformis muscle, gluteus minimus, vastus lateralis, the vastus intermedius, the articularis genu, the capsular ligament, and the adductor magnus. Posteriorly, we have the gluteus medius, the quadrate femoris, the gluteus maximus, the vastus intermedius, and at the lower region we have the medial head of the gastrocnemius, the plantaris, the lateral head of the gastrocnemius, the adductor magnus, the posterior cruciate ligament, and the anterior cruciate ligament. Clinical anatomy of the femur. Due to any accidents, forced medial rotation of the thigh and leg during the fall results in fracture of the shaft of the femur below age of 16 years, bucket handle tear of the medial meniscus between the age 14 and 40 years, Pott's fracture of the leg between the age 40 and 60 years, fracture of the neck of femur over the age of 60 years due to osteoporosis and degeneration of the calcar femorale. The head of the femur is partly supplied by the branch of the obturator artery along the ligamentum teres. The main arterial supply is from retinacular arteries. The branches of the medial femoral circumflex artery. These arteries get injured in intracapsular fracture of the neck of femur, leading to AVN of the head. AVN stands for avascular necrosis. In such cases, the hip joint needs to be replaced. The center of ossification in the lower end of the femur and the upper end of the tibia is seen by X-ray, proves that newborn was nearly full term and was viable. In normal knee joint, the obliquity of the line of quadriceps and its insertion into the tibia results in Q angle. Normally, the Q angle is 15 to 20 degrees. If the angle is increased, there is lateral subluxation of the patella. In upper third of the shaft of femur fracture, the proximal segment is flexed by iliopsoas, laterally rotated by muscles attached to the greater trochanter. The distal segment is pulled upwards by hamstrings and laterally rotated by the adductor muscles.